Hey guys, it's Dr. Dan here. Welcome back to my channel. If you're new to my channel, I am a practicing orthopedic spine surgeon, and here on YouTube I have the highest quality Doctor Reacts videos to medical dramas, including your favorite Grey's Anatomy. So last video I had a special request from Deanna Anderson. Deanna asked for Season 6, Episode 6, I Saw What I Saw. And over 700 of you guys actually agreed with her that this was the episode to react to. So we'll get started with that episode right after this. Before we get started with this episode, I just want to thank all my subscribers for watching my reaction videos and leaving such kind and encouraging comments on all my videos. I'm actually practicing full-time and also a new dad, and I'm pretty tied up. And so hearing the comments really pushes me and encourages me to make higher quality educational videos for all of you. So thank you so much for watching and all of your kind comments. Make sure you like this video down below if you don't want to miss any reaction videos, and also hit the subscribe and bell notifications. Let's get started.
What happened to that patient was inexcusable. And we're going to be here till I find out who's responsible for it. So until then, you will sit down, you will shut up, and you'll wait to be called.
Wow, so that's pretty intense. You guys did warn me that this is going to be a very intense episode. It does sound like something very bad happened to a patient, and Dr. Weber here is going to get down to the bottom of it. Let's see what happens.
Case in point.
Douche. CER. Mass casualty. Hey, I need to, emergency, I'm a surgeon.
Emergency, I'm a surgeon. Pretty funny line. I don't think I'm going to be using that line anytime soon in the hospital personally. So here they're saying that they got paged about a mass casualty event. A mass casualty event occurs when there's a lot of people that got injured, and to a point where it may overwhelm the local healthcare resources or the hospitals in a local area. And that can be anything from a plane crash or a fire, or in these cases in the news, we see a lot of mass shootings, unfortunately. So that would be considered a mass casualty event. And you see all three of these surgeons just jump up and bolt out of the room because they live for this stuff. They want to help and fix patients, and this is an opportunity to do so.
Apparently, he grabbed the fire axe out of the case and tried to run down the stairs with it.
My mom was right, no running on the stairs.
Do not push the axe in. Do not pull the axe out. Do not move. Understand?
Way to go, Dr. Bailey, for putting direct pressure on the bleeding wound right away. Here, it looks like this axe went right into the front of the chest, where this is our breastbone or our sternum. Here, there's actually a lot of critical structures that lie right below the sternum. As you can see from this picture, the heart lives there, very close by. There's the lungs. Off the heart, you can actually see these other vessels that branch off, which are our great vessels, like the arch of the aorta comes right off of the heart, which is really close to where this axe went in. So this is a side view of the mediastinum, which also shows the critical structures that I spoke about. Now, the reason why Dr. Bailey is saying don't move an inch is that she just wants to prevent any type of injury happening to these very critical structures. The heart pumps all the blood to the rest of the body that's been injured, and the axe gets removed. Like you see, you're going to have tremendous bleeding. And so that's what she was worried about, and unfortunately it happened.
Roy Mackinac, 56-year-old firefighter, fell 3 stories from a ladder. Looks like a hip and femur fracture, maybe radius 2. He's waking up.
All right, so Dr. Torres is assessing this patient, and he has a bunch of orthopedic injuries. She said that he has a hip fracture, a femur fracture, and a radius fracture. So we'll go through each of these injuries. Hip x-ray actually looks like this, an uninjured hip, and that's a normal x-ray. A fractured hip actually looks like this on x-ray. You can see that the fracture is pretty obvious. Then normal femur x-ray looks like this, and the femur is that long bone that's actually beneath the hip. And a fractured femur actually looks like this. That's pretty obvious as well. And the way you fix hip fractures and femur fractures is you actually use a metal nail, that you actually use a hammer and you nail down the intramedullary canal of the bone, as you see here. Now, you also can use screws to fix hip fractures as well, and the x-ray after the surgery looks like this. Now, the radius is actually a bone in the wrist. A normal wrist x-ray looks like this, and a fractured wrist looks like this. Pretty obvious. The way you actually fix a wrist fracture with orthopedic surgery is you make an incision over the wrist, you go right down to the bone where the fracture is, and you put it together, and you keep everything together by using plates and screws, as you see on this video. Post-op x-ray looks like this. And you can see there's a lot of metal there in the wrist that's holding that bone together. If you see my eyes light up when I talk about orthopedic surgery, because I'm an orthopedic surgeon, I love this stuff. But back to Grey's Anatomy.
Who's going to check in?
Shepard?
Yeah.
Has uneven pupils.
Abdomen's rigid. He's going to need an ultrasound.
Yeah. It's going to need a head CT too. Page me to get scan.
All right, so Dr. Shepard here is coming in to assess this patient with uneven pupils, and he uses pen light in the eye. And that maneuver, I always wondered before medical school, why are doctors shining a light into the eye? And it's to assess for this condition called anisocoria, which is uneven pupils. And we're going to review a little bit of eye anatomy to understand this. In the eye, there is actually a circular muscle, and that's the colored part of the eye, and that's called the iris. And the hole in the middle of the iris is actually the pupil, and that hole is what lets in light into the eye. When the light is shined into the eye, the pupil actually constricts or gets smaller, and when you're in a dark room where there's no light, the pupil actually opens up and gets larger or dilate. So this is called the pupillary response, and in this video you can see here this patient is getting one eye checked, and you can see the pupillary response and the constriction, but on the other eye you can see that there is no constriction, and if you actually put light in one eye, the other eye should be constricting equally, and when it doesn't, then you have anisocoria. When someone has uneven pupils, that can actually be a sign of a serious brain injury, and that's why Dr. Shepard is asking for a CT scan of the head to assess for that injury.
This patient is bed 1, Kathy Becker. She's complaining of pain.
At this point, who was in charge of Mrs. Becker's care? Whose patient was she?
I was never on her. I was in the OR with Dr. Bailey. I don't...
This is definitely a recipe for disaster where nobody knows who is responsible for this patient. And honestly, this is not very realistic because in residency, every patient is assigned a team, and a team might have an intern, which is the lowest level of resident, and then you have a second-year resident, a third-year resident, and so on and so forth. But every team has a senior resident or a chief resident that is responsible for the care of all the patients, and the buck stops with that chief resident. And so if the attending is upset, something bad happened to a patient or an error was made, they're not going to blame the intern or wonder who was taking care of the patient. They're going to go straight to the chief resident, because that chief resident is 1 year away from becoming a full-blown attending. So this kind of confusion rarely happens in a hospital. It could happen, I guess, in a mass casualty situation where there's chaos in the ER and nobody knows what's going on. Usually it doesn't happen like this.
The burn unit and the ICU are full. All patients are staying here until some more beds open up, all right?
Let's keep the trauma rooms clear for the burn cases, please.
All right, so this is a bad situation unfolding. The hospital is becoming overwhelmed. The flow of patients in a hospital typically is when patients come in, they initially go to the ER or the trauma bay. And in those settings, the patient is stabilized. And when they're stabilized, they get moved into the floor beds upstairs usually, or into an ICU setting, or if they have to go to the operating room, they get moved up. When the hospital starts filling up because there's so many sick patients, then all of a sudden these patients are stuck down in the ER and they're not in a place where they can get appropriate care. But sometimes this can lead to the patient not getting optimal care because the hospital is so overwhelmed.
I can't get a pulse on the Doppler.
Okay, Evan, I have to do an escharotomy now. I have to cut into the burned skin to restore circulation to your arm, okay?
Did you find my dad? You know what? I'll ask again.
So let's talk about an escharotomy. So an eschar can be formed when there is a burn because that burned tissue becomes inelastic and very tough, and that's what's known as the eschar. Now, that eschar can actually cause problems because the tissue underneath the eschar can swell, and the eschar is very constricting, and it traps that swollen tissue, and that can lead to compression of blood vessels. It can lead to nerve damage. It can lead to a lot of bad things. That's why an escharotomy is necessary. And what an escharotomy is, it's an incision made into the eschar to relieve that pressure.
I'm sorry, I know. You're okay, pal. You're gonna be okay.
You got the chest tube in.
That looks really painful, and honestly, this is a bit unrealistic because a patient is just not going to get a escharotomy without any type of anesthesia. A patient would at least, at a minimum, in the ER, get some IV sedatives to make them woozy, more comfortable before such a procedure taken. That's very easy to do through the IV. No matter how urgent or quickly you have to perform it, you still would give the patient some medications. The realistic part of the scene is that Dr. Sloan actually made the escharotomy in the correct place. This is a diagram of where all the escharotomy incisions should be made. In the arm, that's exactly what he did.
You got the chest tube in.
No, I was getting there.
Did you go in below the 5th intercostal space? You could have punctured her diaphragm.
I know, I lost count.
So Dr. Weber here is talking about a chest tube. So what is a chest tube? A chest tube actually is a tube that's placed around the lung and drains air, fluid, or blood away from the space around the lung, which is called the pleural space. And the way it's inserted is actually through the intercostal space, which is the space in between the ribs. So most patients have 12 ribs, and the space in between the ribs is called the intercostal space. So the space in between the first and the second rib is called the first intercostal space. And typically, a chest tube is placed in between the 4th or 5th intercostal space. And Dr. Weber here is saying, did you place it below the 5th intercostal space? And why that's worrisome is that if you go too low, as you see on this picture, you can actually hit the diaphragm. The diaphragm is the muscle that pulls down on the lungs to pull in air. And if that gets injured, it can be pretty serious.
You get the chest tube in.
I did. I did. I just...
She did. She just missed a step.
3, 4. Why did you do that?
I had to. Okay, she was running out of time. It was a tension pneumothorax. You have to relieve the pressure so she doesn't croak before you put the chest tube in.
Tension pneumothorax is actually a condition where there's air trapped in that pleural space around the lungs that actually pushes down and collapses the lung. It's a very dangerous condition. And he's right here that he needed to decompress that tension pneumothorax with a needle decompression. So he used a needle and he put it into the intercostal space, and the air should rush out and treat that tension pneumothorax. Now, what's totally unrealistic here is that he's like stabbing the patient, and there's like absolutely no way that he's super accurate and gets it right into the second intercostal space with this like lunging, stabbing motion. As you can see in this video here, get it right into the second intercostal space to do that needle decompression. You have to be pretty precise, and you have to feel the ribs and get it in nice and slowly. So that is pretty unrealistic.
D-Tech, no pulse.
Start CPR, bagging. Which one would that be?
Charging at 200.
Whoa.
Or that.
So what Dr. Yang does here is she performs a precordial thump. And what that is a maneuver where you take the fist and you strike the front of the patient's chest, and that actually creates a small electrical signal within the heart that can actually restart the heart potentially and fix whatever arrhythmia is happening. It actually has a very low success rate. It is actually in the ACLS guidelines, which is an algorithm that tells healthcare providers how to perform codes, that if there is no electrical paddles available, the defibrillator is not available, then you can try a precordial thump, but may not be successful and probably won't be successful. All right, guys, so I know you're gonna hate me for this, but I am going to end part 1 of this reaction video right here. We're gonna come back in a few days with part 2, where we figure out how this patient died. Make sure you hit the bell notification and the subscribe button so you don't miss part 2. And also in part 2, I'm going to make sure to give you 2 scores for this episode, which is the realism score and the entertainment value score, which I did in my last reaction video. So don't miss out on part 2, guys. Thank you guys so much for being here. I appreciate every single single one of you. Take care, and I'll see you on the next video.